let me say this as I was listening to the introduction. In fact, who I am, what my credentials are, what my experience is, and the same with Neal, what his experience is, the number of years he's been doing this, and all the research is not the point of the seminar. The point of the seminar is the value to you of the evidence that will be presented, the information that will be presented. In the teaching of anti-aging medicine and in the teaching of bioidentical hormones, there are a lot of personalities. And there's a lot of emphasis on expertise. And part of this introduction and part of the experience you will have with receiving information will be a certain conflict of information you may have already received with information that Dr. Rouzier is going to present. But again, I want to emphasize the emphasis is not on personalities and the emphasis is not on expertise. The emphasis should be on the evidence. The onus is on you. And it's on you to be able to discern the value of what will be presented. To choose and select the issues that will be raised, and to be able to identify and answer the questions yourself. Does this have value? And why does it have value? So that's the first thing. When we see patients, we do a great deal of blood work. And we do it very differently than is often done in physicians' offices, where there really isn't time taken to go over the results. Because in medicine, most of the emphasis and most of the attention is on pathology. It's on disease. So if there doesn't appear to be any disease or any pathology in the lab report, generally the patient is told everything's fine. And yet for most of the patients that we see in this larger field of hormone function and anti-aging medicine, they know something's not right. They know they don't feel right. And that's actually how we in the alternative field or the complementary field or in naturopathic medicine, where I've been trained, see so many patients. They come out of dissatisfaction because physicians don't talk to them. They don't explain things to them. They don't try to hear about why the patient doesn't feel well, even if there isn't pathology, or at least pathology that appears on the lab report. So we go through and we break down and we look at the nuance of the blood tests. We talk about the difference between that which is normal and that which is optimal. We talk about it from the point of view that the problem with normal is it always gets worse. And so we try to prepare and present this idea of optimal, which is particularly relevant as we're all getting older. Because if it's all about just staying within the normal range, and yet with age, changes are taking place and we don't adjust for age, then the issues that arise with regard to illness or wellness or optimal health comes into challenge. But sometimes when I review the labs and I'm going over everything in the way that I look at it, everything looks fine. So I say to the patients, well, I have good news and I have bad news. And the good news is everything looks fine, even by my standard. And then I'll say, and the bad news is, everything looks fine. Because people want something to define from their lab work. And so from that point, we then look at and discover what isn't shown in the blood work. Well, for you today, I have good news and I have bad news. The good news is this is a highly educated group of people. You are professionals. You have taken many courses. You've had a great deal of study in your life. Many of you may be experts in your field. Certainly, most of you have a great deal of experience. That's the good news. The bad news is you have a great deal of information. You have studied for a long time. Many of you may be experts in your field. Many of you have taken courses and seminars. So the challenge is, as Neal was referring, how do you open your minds? How do you make space for information that may come in conflict with the information you already have? Now, I'm always looking for signs. I mean, not actively, but once in a while there's signs. So I flew in on an overnight flight from Maui. And when the flight attendant asked me what I wanted to drink, I asked for water and orange juice. The water and orange juice were poured without ice. And when I went to pick up the orange juice, and I'm drinking it, I look down and I see the service napkin. And the service napkin says, ideas are best pursued with 280,000 horsepower engines. I thought to myself, ideas are best pursued with 280,000 horsepower engines. A sign. I thought, ideas are best pursued with an open mind, with the ability and the capacity to receive information after information has already been placed within that brain. So in the absence of horsepower is the need to be receptive, is to need to be open to ideas. And then it says, keep climbing. Delta Airlines. Well, then I picked up the water. As I'm drinking the water, there's another service napkin. And the service napkin says, we move the people who move the world. Well, that would be you. That would be you. And I thought, with the pursuit of information and the pursuit of ideas and the enhancing of information as it relates to the evidence in bioidentical hormones, you can make an even greater contribution. I guess I should disclose one more thing on behalf of the Hawaii Visitors Bureau. How many people here have been to Hawaii? A few. Yeah, okay, good. All right. And do you all understand that when that plane is flown from the US mainland to Hawaii, it does not fly in a straight line? And then when I fly from Hawaii to here, that plane does not fly in a straight line. You know that? That plane is in a constant state of correction. That black box and that navigational system are talking to one another. So that plane is moving in this direction, correcting as it's moving forward. And that's the same thing in the receiving of information that will be presented over the next 3 days. It's a process of correction. It's a process of using the information you have and applying it to new information that may be presented that again comes in conflict with what you may already know. And to see if correction can be made so you can make the most out of the information. So I was first introduced to bioidentical hormones in 1977. That was my senior year in naturopathic medical school. And following graduation, I moved to the East Coast to open up a clinic and began to practice first in Boston and then in New York. And I had become so enamored with the concept of bioidentical hormones that I began to collect as much information as I could. But the way that I was trained was under the belief that there weren't a lot of studies to validate bioidentical hormones. That the studies were mostly conducted by big pharma, and they certainly didn't want to do studies on bioidentical hormones. So I collected articles and collected as much information as I could. I would attend courses for which there were not a great many up until the 1990s, and I attended courses through the Broda Barnes Foundation in Comfort Court. And most of the physicians that I studied with were from Europe. Michael Hansen from Denmark, Malcolm Carruthers from England. Some of you may know Terry Hertog. I studied with Jacques Hertog, his father, from Belgium. A great many of the European physicians where much of the information was coming from. And when we studied back then, there wasn't a lot of discussion about evidence-based medicine. There was evidence and there was study, but it also was based on a great deal of experience. And so for the first 25 years of my practice, it was empirically based. It was based on experience. And it was based on the learning from what I had originally been trained to do, and then to ask the patient, how are you feeling? How are you doing? How are your hot flashes? How are your night sweats? How are your mood swings? And based on the feedback I received, I established a practice and I established what I felt was an expertise. And at the time, even though I knew it, I wasn't fully discerning the distinction between when patients come in to receive treatment, the basis on which they may consider hormone replacement falls into two separate and distinct categories. Category one is symptom-based. And those symptoms may be a hot flash, a night sweat, mood swings, sleep disturbances, and vaginal dryness. Those symptoms may be evolved. They may include libido and sex drive or cognitive function. Those are symptoms. But the studies that you will hear about over these next 3 days and the emphasis to those studies really do not so much talk about hot flashes and night sweats. What they talk about is the risk to the number one cause of death of women in the United States, which is heart disease. Second leading overall cause of death of women in the United States, bone loss and osteoporosis. There will be more women who will die as a result of heart disease than all cancers combined. The studies also talk about Alzheimer's and dementia, colon cancer, and macular degeneration. And so, when studying and talking to patients, my emphasis was, how are you feeling? While in the back of my mind, I knew that the hormones would help long-term health and be beneficial, but my attention through my training was on symptom, empirical. In 2002, the Women's Health Initiative study was published. And now I can think back of the conflict that took place at the time of that study, which up to that point was the largest study to date of women dealing with hormones. Now, there were many, many parts of that study that would be proven to be questionable, and you'll hear a great deal about that over these next 3 days. But what happened is most of my patients came in and were concerned about the study and whether the hormones that we were presenting, the bioidentical hormones, would be of harm. And I, to the best of my ability, said, no, this is different. These do not provide the same risk as Prempro, as Premarin. But I really did have the data, the information that I wanted to have to support that thinking. I knew it, I had studied, but there wasn't the data, the information, the studies, because I didn't believe they existed. So by 2005, I began to think I wanted to do more study. I wanted to get back into seminar training. I had kind of broken away from it for a couple of 3 years because it was difficult for me to find somebody who was adding to the knowledge I already had. That I began to feel that seminars I had gone to or conventions I was going to were not adding to what I already knew. And so I looked up evidence-based medicine. And one of the resources was something called Age Management Medical Group, which in the early years proved to be very valuable. There was good information, good discussion that took place. And then I saw this seminar taught by a man named Neal Rouzier. And I didn't really know anything about him, and I really didn't look up that much about him, but I was interested in how it described evidence-based medicine. And so I went to the workshop, this workshop, the #1 workshop, and I can remember walking in. I remember seeing Dana with a big smile on her face and handing me this notebook. And I can remember thinking in my mind, now what is he going to teach me? What more does he know that I don't already know? And so I took the book and I sat down and I opened it up. Now this is when Neal was still doing overheads. So he had in the front the table set up and all the piles of information that would be presented on an overhead screen, which didn't bother me. But I opened up the book, and all of a sudden, I saw study after study after study after study. And even more amazing is each study was underlined. The information, the salient information was underlined. And over the next 3 days, I was fascinated to see how much research had been done on bioidentical hormones through medical research and medical science. After that seminar, of course, I was motivated to go the second. Same experience, overhead, table set up, Neal going through, laying it out. But the same experience with the notebook, opening it up, going through study after study after study. Again, I would go back to my home, I would take out the information, separate it out into varying categories of where it was relevant, and began to collect the data and review it. Third seminar, same thing. At that time, we didn't have a fourth seminar. Well, to date, I've attended maybe 13 of the seminars. They're actually 4, but I've attended them 13 times. And it's not because, as Neal implied, I was doing anything wrong. I was actually quite content and felt quite successful with what I was doing over the previous 25 years. But what was lacking was the connection between the evidence and the way I was practicing. So that in talking to Ms. Jones about how she felt and about her symptoms, I was missing a critical component as it related to heart disease, bone loss and osteoporosis, Alzheimer's and dementia, colon cancer, and macular degeneration. And so what I began to learn about, as I will talk about, is a standard of care. And within that standard of care, there are endpoints. If you are here because you believe in the value of evidence-based medicine, and you, in fact, may have attended conferences that speak to the point of evidence-based medicine, the question then comes, first of all, what kind of study it was, how it was conducted, and then within that study, if there is value that is shown, what was the formula that was being used? What hormones were being used? And then if there is value, at the end of that study, what was the concentration of those hormones? And then finally, if you test the blood, what is the outcome that correlates with benefit? That is the endpoint, and that is the standard of care, and that is the reason for being here, is to understand and define the meaning of evidence and how that evidence is applied in your practice. So now, if I speak to Ms. Jones and I review how she's feeling, we've also done blood work. And we're going to do blood work on estradiol. We're going to do blood work on progesterone. We're going to do blood work on other hormones. So the question that comes up and the potential conflict is, if someone has suggested doing saliva testing is better, or a 24-hour urine is better, or you're going to learn that the use of the oral form has specific benefit with regard to heart disease and the application of women, and yet in most of the conferences and most of the seminars that I'm familiar with, the emphasis and the attention has been on cream. And I would bet, if I were to ask, of those of you who have been using bioidentical hormones, how many are using an oral form and how many are using a cream form, most of you would probably be applying a cream form because you have been taught it is safer. Because you bypass the liver, and by bypassing the liver, you avoid the risk to DVT and you avoid the risk to stroke. You're in for a surprise. If that is part of the belief system or the standard of care, then it will become important to understand why that is not supported by the evidence and why it's not supported by the evidence. So Frank Zappa has said, a mind is like a parachute. It doesn't work if it is not open. This is an old Indian parable. It originally was with a group of Indian wise men. And each of the people here are positioned around this elephant. Each is asked to describe the elephant. And the parable says, and so these men of Hindustan disputed loud and long, each in his own opinion, exceeding stiff and strong, though each was partly in the right, and all were in the wrong. I mentioned that in 2005, when I started to look more seriously at evidence-based medicine, and I don't mean to badmouth any conferences, seminars, or any individual, but I mentioned the AAMG, which at the time I thought would be a more professional and upgraded group in anti-aging medicine because of its detail to evidence. And I've attended that over many, many, many years. And one of the things that I find most fascinating is to hear lectures in which there's a conflict of information. Now, I've happened to have heard Neal there many times. And it fascinates me that he presents the evidence in great detail. And then someone comes up who is also an expert in the afternoon and contradicts that information. Now, my point here isn't that Neal is right and this other person is wrong, not at all. What is fascinating to me is that we go to these conferences and we go to these seminars, and the people who put them together and organize them, nobody questions this. The information is presented to large groups of people, and yet nobody is questioning, why is this expert saying this and this expert is saying that? A few years back, that question was burning inside of me, and after a group of speakers had spoken at the AAMG, they were up in a panel and they were asking for questions, and I got up and I asked that question. If everybody is expert, and if the information is all based on evidence, why is there a different outcome? Why is there a difference in information? And there was silence. This empty silence. And finally, the the lead speaker said, well, it's because we all come from different backgrounds. We have different expertise. That didn't make any sense to me. And rather than take up time and go through the questioning of, well, that doesn't make any sense, evidence is evidence. If we're using evidence that is based on scientific study and scientific research, there should be some standard of care. So, if you've been taught, if you've learned, if you believe, for instance, that cream is better than the oral form, well, let's look at the evidence. Let's put the information together and see why and where this conflict comes from, and see if we can sort out to the place that allows you to be comfortable in your prescribing protocol. If there's evidence, there should be some standardization and there should be some consistency. So, as we learn, as we gather information, and now this portion is making the obvious apparent, meaning much of this I know you know, but I'm bringing it out in the hopes that it encourages you to question as we go forward and as you listen to Neal over the next 3 days. We all have personal filters, pretty obvious, right? We all learn what we learn, we gather information, and we develop opinions about that information that we gather. We have a contextual bias, and that bias is represented by the group of which we participate in or the learning environment from which that information came from. There's a bias of information. Again, not bad, not good, not right, not wrong. They're just information that we've gathered. If you've been trained as a medical doctor, there's a contextual bias. If you've been trained as a naturopathic physician, there's a contextual bias. Then it's the same thing in all the fields, depending on the environment and the group from which you've learned information. There's a bias that develops which sets up a filtering system from which, as new information comes in, it has to be filtered through that bias or through that prejudice. Ultimately, then, it's asking the correct question. With information bias, it's how information or data, which is initially implanted in our minds, can remain cemented in such a way that our brains will not receive conflicting data or information to change that which was first implanted. In the latter part of my presentation, I presented 2 letters that had come in from 2 physicians to Neal. And it speaks to this point. And so what I'm trying to do in this presentation this morning is save you from that conflict, is to save you from the information that you've either learned or believed, because in my experience from having attended as many seminars as I have, is to know the conflict of information that is presented that is often different than what you may have heard from other seminars or other instructors. These are just other ways of talking about our own personal filters. Gravitational thinking. I'm fascinated by, within the anti-aging movement and with all these seminars, there's certification programs. And these certification programs give us sometimes the belief that by having that certification, it better validates who we are, and we can put that up, we can present it, we can put it in our bio, and it raises a level of credibility. And yet, again, the challenge with these certification programs is they all present a different standard of care and a different way of practice that can create a certain gravitational thinking. If you've put money, if you put time, if you put energy, if you put effort into that certification, you want to believe that it's correct. The confirmational bias is the same kind of idea. If enough people say, for instance, that avoiding the capsule is the most important thing, well then, by virtue of numbers, that's what you're going to believe. So it requires a much greater discernment. If somebody is suggesting something different, to interpret, again, the evidence and to hear the relevance of the studies that have been done that may suggest something different. The coconut wireless, this is from Hawaii, right? So the coconut wireless is that where somebody tells somebody a story, who then tells somebody else a story, who then tells somebody else a story, and by the time it gets down the line, the story has been completely changed. And so that's what often happens in the context of conventions and seminars, where somebody says something to which then somebody else says something because they become expert, and then they pass it down as an instructor and a teacher, and it becomes something different. Called the coconut wireless. So medicine as we know it has been very successful in evolving the science of disease diagnosis and treatment over the past 6 decades. It hasn't been as successful in the promotion of healthy aging and prevention, which is really what bioidentical hormones are about, right? I mean, it's really a larger approach to wellness. It's an approach to health. So, as I suggested earlier, it's not just about symptom improvement. It's also about long-term health, which incorporates the concepts of prevention, of wellness. The expectation of good health provides opportunities for the increasing disillusionment with the disease care system that is focused on the diagnosis and the treatment of disease. Where I'm from, on Maui, there's not a medical doctor who supports the idea of hormone replacement. It's astounding to me. And there are physicians who had previously and that have changed. Now, fortunately, I've been there for so long. I've been there now for almost 35 years, and I share patients with many of these physicians. And so I've been able to establish a credibility, and when patients go in and they say, oh, no, I feel great. I feel better than I've ever felt before. Or what remains to me to be one of the most significant aspects of hormone replacement and one of the most impactful symptoms that I see is when women come in and say to me, just tell me I'm not going crazy. Tell me I'm not losing my mind. So there's impact when somebody comes in and is disabled by hot flashes and night sweats. It's impactful when a woman comes in and can't sleep. And I remind her that there's a reason we use sleep deprivation as a torture technique. All of those are impactful. But to have the experience of someone come in, especially from a community of women I know or have known or know somebody who knows somebody, and they sit down and they sit in front of me and say to me, just tell me I'm not going crazy. Tell me I'm not losing my mind. And in that moment, there's that human experience of empathy, of knowing that feeling, of having heard it so many times, and the enthusiasm, the excitement that I can change this, that I can help this, and I can make a difference. And so it becomes that much more impactful because there are a community of physicians who are not offering that assistance, who are not offering that support. One of the things that we'll talk about a little bit later is the conflict that may come out of your peers, your colleagues, which is a whole other aspect of the training. You have the information, you're providing the information, and if you're not the gynecologist and you're the PCP, or you're of a different credentialing, and you have to deal with your community of physicians, that raises a whole nother level of question of how you approach that if the doctors in your community disagree. That's why I've taken this course so many times. Not because I didn't get it. Not because he's a bad instructor, far from it. Far from it. It's the information that keeps being added. It's going back and picking out each of the parts of the value and the evidence in each of the sections, the heart, the brain, the risk to cancer, et cetera, and separating them out so I have the data and information, so when the question comes up, I can both present it to the patient, and in those cases where the physician is willing and open to hear, to the physician. Because most of the physicians in my area believe there is no difference between the synthetic hormones and the natural hormones. So that's first thing, it's the same. Natural micronized progesterone is going to have the same negative effect as the progestin has shown. Estrogen is estrogen. There's no difference. And the next is compound pharmacies are not regulated by the FDA, so you don't know what you're getting. Those are the two conflicts that will come up. It's the same, there's no difference, not FDA approved. So ultimately, it's about asking the right question. Again, you're here, knowledgeable, smart, experienced people. Expert in your field, successful in your field. Now, a new set of information is coming forward. The need is to recognize that which is filtered, that which is prejudiced, and to ask the right question. Knowledge is having the right answer. Intelligence is asking the right question. The first question is, what is the standard of care? What standard are we using to determine the value and the efficacy in the practice of our patients? So the protocols we are using, what is the standard of care, and what is the validity of that standard? Should we follow evidence-based guidelines, adhere to a medical research and scientific standards in which our therapy demonstrates scientific efficacy of hormone replacement therapy as carried out in medical research studies? This is information that I've extracted from Neal over the years. And this is something I've replayed in my mind over and over again. So as I said, it really wasn't that I was doing it wrong. It was that I was doing it incomplete. I was doing it insufficient. I wasn't doing blood tests. I was challenged because within my profession, within the alternative field, saliva testing, 24-hour urines are held in high regard. In some part because it's different, because it's creative, because it gives you a more functional outcome, which I don't believe is true, which the evidence doesn't support, which you'll hear more about. But the point being is, again, the emphasis was on the symptom and not the long-term health improvement, the efficacy of the treatment, and how it was evidence supported. So what are our treatment goals? Bioidentical hormone therapy to adequately reflect therapeutic blood levels. Again, I've said this now a few times. Some of you may believe that there are other forms of testing that hold more value, more beneficial functional outcome as you've been trained. Neal will present information and the evidence as to why blood levels are still the standard. In some part, I can simply say, if we say we have evidence-based and we have scientific information, all those studies, if we believe them, if they are efficacious, are all done with blood. There's no evidence-based studies from the NIH or the European studies that are done with saliva or done with 24-hour urines. whatever those who are presenting that information are saying, it's still not the standard of review. And ultimately, we want to preserve function. Again, what is our endpoint? And again, this becomes very, very important, and this is what I've talked about in terms of the patients that I was treating over 2 decades. Symptoms may improve for patients on bioidentical hormone therapy. In fact, symptoms may improve by over-the-counter creams. Symptoms may improve by yoga. Symptoms may improve by Tai Chi, yoga, acupuncture, diet. Symptoms may improve. My experience, because I'm also an acupuncturist, is that improvement is limited. So you can get improvement in the early onset stages of women in the menopause. You can do diet, you can do nutrition, you can do supplementation, but over time, the symptoms will tend to return. And in the context of bioidentical hormone replacement, we may be able to improve symptoms. However, our dosing protocols and testing levels may not provide the long-term protection and benefit to the cardiovascular system, the musculoskeletal system, breast and uterus, brain, colon, and eyes. 2 separate categories: symptom-based, long-term health-based. So when we look at the studies, when we evaluate the efficacy and the benefit of studies, we're looking at long-term health that established a protocol with an endpoint that helped define our treatment goals. So here, and again, Neal will talk to this and expound on this to a great degree, the discrepancy in evidence-based medicine. And this is a title that I've used now over a long period of time, and it's born out of the attending of seminars and attending of the conventions and seeing this conflict of information. If everybody is talking about evidence-based, if everybody is an expert with years of experience, why is there a discrepancy? Inappropriate low concentrations of compounded hormones provide subtherapeutic, non-efficacious levels of hormones. Progesterone is a transdermal cream, or an estrogen is a biester, a triester, an estriol formula, providing blood levels of a subtherapeutic range and therefore too low to provide any protection. Again, I'm presenting ideas here, things to consider, the detail of which will be expounded on over the next 3 days and in additional seminars. But to get the concept, to get the idea, because herein lies where the conflict of filters arise. What is in a number? Well, this is a whole series of lectures unto itself. Why? Because when we think of estrogen, and we think about therapeutic levels, and we think about it in the context of heart, bone, brain, eyes, and colon, as I've already suggested to you, there's a therapeutic level. We'll talk about that. In the same way on progesterone. Progesterone provides a therapeutic level if it's prescribed correctly. And as I suggested in the slide before that, if, depending on the way that it is prescribed, it does not provide a therapeutic level as determined by blood, you will not have a therapeutic outcome. You will not have the protection that study after study after study shows that progesterone provides. But what about thyroid? Thyroid. That's a little different. We have numbers, but what if the number goes a little bit outside the range? What if you're running a free T3 and a free T4 and the number goes outside the laboratory reference range? Then what do? Well, the first thing you do is ask the patient how they feel. You know and have a baseline from when they came in, but then the question is, how do you feel on the thyroid hormone? Now, the chances are there's going to be one of 2 answers. Either 1, I feel great, or number 2, can we raise it? but the number is a little above. So numbers are relevant to the hormone that you're using. So in the case of thyroid, Neal will talk about when do you take your hormone relative to when you take your blood test. And we usually talk about 5-6 hours. So you want to have at least 5 hours from the time that you've taken the hormone to the time you've taken the test. In our experience with thyroid, don't take it for 24 hours. And the reason being is because part of the return of the lab information is probably also going to go to their other doctors. So if their other doctors see levels that are outside the normal range, is going to create an enormous amount of conflict. A lot of conflict. So we may have that patient not take that thyroid for 24 hours to maybe get a little bit more acceptable level, and then interact and talk with the patient to see if we need to raise those levels or change those levels. So thyroid can be a little bit different. What about testosterone cream? If you're using a transdermal cream, well, creams have a tendency to pool. So even after 24 hours, the levels may still come back high. What's the risk with high testosterone in females? Well, there's really no risk. There's side effect. There may be increased hair growth. There may be change in voice. We had a singer who had to come off the thyroid because it kind of changed her vocal cords. Aggression. We don't really see that. Of course, now in today's environment, we actually support that. But we encourage that. So there's not a risk. There can be side effects. But if the numbers are outside, we talk to the patient and we find out how they're feeling, what they're noticing. So creams are tricky because they will tend to pool. We still have a reference range, but that reference range is used with clinical application and experience based on how the patient feels. Okay? Again, I'm introducing a concept here. It's Neal's job to elaborate. That's what's in a number. 2 patients. How many practitioners here treat thyroid? Yeah. Good. Okay. This is probably the single most common issue that comes up for me with regard to hormone discrepancies and the conflict with the standard of care. So I have here 2 patients, and the tests that we ran was a TSH, a free T3, and a free T4. Everybody pretty familiar with those tests? Okay? All right. Patient number 1 is a 54-year-old woman. Her free T3 came in at 3.0, so that's well within the normal range depending on labs that you use. Upper range can be 3.8, 4.0, so 3.0 is well within the normal range. Her free T4 is 1.0. That's also well within the normal range, right? Upper end, depending on the labs that you use, 1.6, 1.8. Okay? All right. Now her TSH came in at 0.09. 0.09. And the low end on most labs is what? Is about 0.36 or 0.39. So that's well below the normal range. Okay? That TSH is suppressed. On patient number 2, the free T4 is 1.28. Again, well within the normal range. The free T3 is 3.2. Again, well within the normal range. and the TSH is 0.056. Again, suppressed. Okay? So we have two patients, both in their 50s, T3, free T4 in the normal range, and the TSH is suppressed. With one of the patients, her doctor wrote this letter. Hi, Miss. Your TSH is suppressed, which is consistent with early hyperthyroidism, also known as subclinical hyperthyroidism. This is concerning because it can increase your risk for osteoporosis and certain types of potentially dangerous irregular heart rhythms. Fortunately, your bone density test of last year looked good. Having a normal T3 and normal T4 can be a false reassurance since the TSH test is a much more sensitive testing. Please be sure to discuss this with Dr. Kern, as he should be very familiar with this condition. Okay? Fair communication? Let me ask you, of those who practice thyroid treatments, of what this physician wrote and the risk and the concern for the subclinical hyperthyroidism, how many believe that this physician is correct, or that you would practice similarly to what this physician is suggesting? Anyone? Okay. Some reluctant. How many practice thyroid here? How many practice like that? It's here. Okay. No one's being judged here. I just kind of want to make a point. So, is it only these three? Is there anybody else that? Yeah, I don't want to get too much into the patient. It's a good question. Those are the questions that Neal will go over in greater detail. It's mostly this issue of a suppressed TSH. And the reason I bring it up, the example I use it, and the question I have, which I would expect more of you actually to have answered in the affirmative, if you as a practicing physician have received a suppressed TSH, there has to be some concern there, right? That would go without saying, because why? Well, we've been trained that a suppressed TSH correlates with hyperthyroid, and hyperthyroid correlates with an increased risk to stroke, or, although only the result of one study really, loss of bone, right? So if you have a suppressed TSH, there could be a problem. Unfortunately, that's not what the evidence necessarily shows. So if you have a suppressed TSH and you have free T3 or free T4 in the normal range, and you actually ask the patient how do they feel, and you don't have any signs of hyperthyroidism, they don't feel anxious, they're having trouble sleeping, their heart rate hasn't gone up, their pulse rate hasn't gone up, but their TSH is suppressed. TSH by itself does not necessarily correlate with hyperthyroidism. But this is the single most common issue that comes up over and over and over again, because we treat a lot of patients for thyroid. And so once you start taking thyroid, there's a negative feedback loop that goes to the brain, that TSH will go down. Again, the point of that, the evidence to back that, Neal will elaborate on and get into on thyroid. The point I'm making for this part of the conversation has to do with the conflict of information. If, which is very standard, a suppressed TSH associated with hyperthyroid symptoms, and now you may hear information that contradicts that, that can create the conflict of ideas. And again, as I say, it just happens to be something that came up this last week, and it is by far and away the most common thing that I deal with regard to the hormone conflict. I keep a little note on my laptop for patients, or on the rare occasion where I go ahead and send it to the physician with all due respect. not trying to be right versus somebody else, but just to point out and provide the data, the information. Neal has done a webinar on this. There's other information that's come out quite a bit in his study and research and information. So just an example of potential of conflict. We've been talking about evidence-based, medical research and scientific standards that demonstrate scientific efficacy of hormone replacement as carried out in medical research studies. This then is the standard. This is what I was talking about as it related to my original empirical application, my empirical, how do you feel, Ms. Jones? To expand to include evidence-based efficacy. These I just put down to reference many of the studies that Neal will speak to over the course of the next few days. I'm not going to go through, define any of these. That wouldn't be purposeful in this section. And again, the reason I put it down is because over the years, in the collecting of information and being at these seminars, I've taken many of these studies and I've put them down and I make little notes under each of those studies. Because this represents the evidence and the efficacy for the bioidentical hormones that include oral form estradiol, certain concentration of progesterone, and its effect on the heart, the brain, the bone, the eyes, the colon. With regard to the studies, you can begin to organize the information if you're going to attend other, seminars to begin to see where the evidence is based on the various studies. Neal will go into greater detail about what represents the validity of a certain study, and then give you the detail in reference to that study. This is just a guide or a blueprint. I'll say one thing about the WHI, which is, again, one of the most popular modern day studies that has put fear into most physicians and the reason why they tend to be against hormones. And in that study, one of the most important things to know is how, when looking at a study, the difference between percentage numbers and absolute numbers. So for instance, if there's a study in which 1 in 10,000, there has been an increase to 3 in 10,000, that is a 300% increase. If the information is presented as a 300% increase, that's pretty dramatic. But if in another study, there's been an increase of 100 in 10,000 to 300 in 10,000, that also is a 300% increase. In the WHI study, the initial information was presented in percentages. When Neal goes through that, he will explain it in absolute numbers, because when you look at the absolute number of increase in risk to stroke and heart disease and risk to breast cancer, the actual number is actually low. So an increase of 100 in 10,000 and 300 in 10,000 is a much more dramatic increase, right, than 1 in 10,000 to 3 in 10,000. Both 300%, but the absolute number is where the difference is. That's what's important to keep in mind in reviewing the studies. Cause and effect. You will hear this over and over again in each of the studies. And this speaks to the conflict of information that you may hear through other seminars. Observation does not prove causation. And association does not prove causation. So in studies, where as it relates, say, to estrogen, and as it relates to potential risk to breast cancer, the more direct association is going to be to the visceral fat and not to the estrogen. The visceral fat raises estrogen levels, which is not specifically then related to the risk to the breast cancer, that Neal will go into great detail in explaining, and he will repeat this over and over again in the studies. Observation as an observational study and association does not prove causation, the meaning of which will become much clearer when he goes through the studies. At Christmas time, I received a card from one of my patients. And in the card was this saying, which is biblical conversation that took place. Part of that conversation, then you will know the truth, and the truth will set you free. I have a beautiful line, but when I got the card and I looked at it and I thought about it, there was a part of reading that felt true, right? We study, we learn, we develop experience, wisdom, and ultimately, say, as young people and as we grow older with maturity, we learn more about what the truth really is, and we like to think that the truth will set us free. Then I thought about it in the context of Neal's presentation, Neal's seminar, and the information you will hear over the next few days. And in my morning earlier session, I was talking about the conflict of information, the dealing with the filters of information that we deal with, such that the truth may not set you free. The truth actually may create conflict. And to that end, I have a couple of examples. So I'm not going to go through each slide. I think you have this information, and if you don't mind, I have it written out. Well, actually, I guess I could read it just as easy from here. So maybe I will go through it. And I'm going to try to go through it quickly. What I have here are two examples of where the truth can create conflict, and they are what I consider to be excellent and exceptional examples of how leaving this seminar can create certain conflict. So let's go through. So here's a physician that's writing to Neal. I have attended 7 weekends with Worldlink Medical so far. I will attend part 3, making my 8th course. It is not a relaxing weekend, as I am typing notes the whole time, but every course is well worth it because I am a lone practitioner, need all the confidence I can get. Thank you, Neal, for your expertise in teaching. Now, I must vent. In my insurance primary care practice last month, I saw a new patient, 50-year-old, with multiple common menopausal complaints, hot flashes, vaginal dryness, anxiety, moody, diabetic, vaginal yeast after a year, hypertension. The last period was 2 years ago with a menstrual bleed last month. She even tells me, quote, I think I have to be going through menopause. She has a routine gynecological exam coming up, so I ordered labs that she can share with her gynecologist and prepare her that she will need a pelvic ultrasound and possibly endometrial biopsy with her gynecologist. I see the patient in the follow-up week, and the labs are as follows. FSH, 56. Okay? Menopause, good, okay. But I am still unable to find a source or documentation of this. In light of the persisting controversy on whether to block testosterone's conversion to estradiol with aromatase inhibitors, I would like more evidence-based information. I understand Neal's stance on achieving higher estrogen levels, but when I sit in lectures at AMMG, I have other smart, experienced experts that say to block it down to less than 25, it gets confusing. Help. So, again, the detail of information here that you will hear, if not today or this week, in other seminars, is what has been the standard of care in most of the seminars and conventions in anti-aging medicine. Everybody seems to want to lower estrogen in men, and everybody wants to believe that estrogen is attributed to prostate cancer or other issues related to men. To the best of my knowledge and to the exposure that I've had over these many years, Neal is one of the few physicians that applies the evidence that indicates that estrogen is beneficial to men. In the same way it is beneficial to women, it has benefit to men. And in much greater detail than I'm going to go into right now, that will be explained. So here is the nature of this physician's comments. When we're replacing testosterone in men and we have the conversion into estradiol, there's great evidence to support that benefit. Every other doctor talks about blocking. And this is a conflict that I have with AAMG, that nobody is seeing this, listening to it, who leads the conference, who then says, okay, well, let's have a conversation. Let's see where the evidence lies so it can be sorted out for the attendees, not just to get this conflicting information. That's how I would do it. So here's Neal's response. I cannot give you the lecture here, as it is a 2-hour lecture presented in part 4. It is all an evidence-based lecture. If you don't grasp what I have explained, then go ahead, block estrogen. And there's links that he sent to this doctor, and you'll have links and evidence and information. However, no one that gives a lecture at AMMG can provide data or studies to support their need to block estrogen other than observational studies that are baseline observations that do not prove causation. So again, association does not prove causation. Importantly, this is the issue I raised earlier about understanding what our standard is. What is the standard of care? What is the discernment of evidence? The question that you ask yourself in order to determine whether the information that you'll hear over this weekend is valid and is applicable to your practice, to minimize the conflict and to give you the potential for the best outcome. And I, through my own experience now over, as I say, what's it been? From the first 25 years to the last 15 years has been the application of a more evidence-based approach, which has raised the level of credibility in my practice and the success of what I already considered a successful practice, but a much more fulfilling experience. Every outcome study demonstrates harm which all lecturers at AMMG ignore. I gave this lecture this past week, and also one of the attendees approached me afterward and said that now that he understands it, he finds it amazing that others still don't grasp it. So if you desire to increase cholesterol, visceral fat, subcutaneous fat, decrease your libido, and orgasmic function, then yes, you can block estrogen. Good luck with that. Over 50% of the benefit of testosterone is from aromatization into estrogen that you lose when you block it. Neal, P.S. My challenge to you is to provide, as you state, evidence that blocking is beneficial. I'll wait by my facts. Again, there is much more information to that. I'm just introducing you to this idea of testosterone as transference, aromatization into estrogen. The more important point here is the potential conflict and the understanding of that as you go to other conferences, which I think I've pretty well spoken to for most of the morning. PSS. The other smart, experienced experts are clueless and don't grasp that observation does not prove causation or J point in elevation. Others may weigh in. I do agree, however, that I apparently am the only one on this side of the fence. No, there's 2 of us. How can all of them be wrong and I be right? Seeing that everyone disagrees with me, then I must be the one that is wrong and that does not understand it correctly. So please help me understand that which I don't understand, and then see the attached. The first comment I made this morning, it isn't about personality. It doesn't matter about the expertise. Well, it does. I mean, that's what brings you here. But the point of the weekend and any continuation is to take the information and discern for yourself, does this represent evidence as reflected in medical study and medical research? And if it does, then that should represent a standard of care and an end goal in terms of the practice to achieve efficacy and success. That finished my morning session. Thank you all for your attentiveness. I very, very much appreciate it. When we get back, my friend Neal Rouzier will lecture. Thank you.